Hello, everyone, and welcome to our first full inaugural episode of the ASSFN podcast. My name is Danica Paulo. I'm a Vanderbilt neurosurgery resident, and I'm here today with Dr. Rashna Ali and our guest speaker, Dr. Samir Sheth. And we are very excited today to talk to you about the topic of deep brain stimulation for obsessive-compulsive disorder. So as a brief history, obsessive-compulsive disorder is an anxiety disorder that is characterized by intrusive thoughts and repetitive compulsive actions that really interfere with patients' quality of life. Overall, there's about a lifetime prevalence of 2 to 3% of OCD in US adults. Initially, psychotherapy and medication remain the mainstays of treatment, but in about 20 to 40% of patients, they are medically refractory and they require further treatment. Typically, symptom severity is commonly determined by the Yale-Brown Obsessive-Compulsive Scale, or the YBOX, which is a subjective 10-item scale. It includes 5 rating dimensions graded from 0, meaning no symptoms, to 4 for extreme symptoms, for obsessions and compulsions. And these include dimensions of time spent or occupied by their obsessions and compulsions, interference with functioning or their relationships, the degree of distress that their disorder causes them, resistance, and control. Initially, ablative procedures such as cingulotomy and capsulotomy showed promising results for these patients, with about a 37% and 57% YBOX score reduction at 12-month follow-up, respectively. But these are permanent lesions. The advantage to deep brain stimulation is that it is a neuromodulatory, reversible, and titratable treatment option. So deep brain stimulation was initially used for patients with movement disorders, and it was noted that patients with comorbid psychiatric conditions, this therapy yielded unexpected improvements in both mood and compulsions. So this discovery paired with the knowledge of improvement with anterior cingulate and anterior limb of the internal capsule lesioning led to the development of applying deep brain stimulation to obsessive compulsive disorder. To date, currently, there are hundreds of patients who have received deep brain stimulation for obsessive compulsive disorder worldwide, and many more patients do qualify, but either do not receive this therapy or do not wish to pursue deep brain stimulation due to various barriers or patient preferences. The first anecdotal reports of deep brain stimulation for obsessive-compulsive disorder were published in 1999, so relatively recent. And multiple targets have since been evaluated for this therapy, including the anterior limb of the internal capsule, ventral capsule and ventral striatum, the nucleus accumbens, the inferior thalamic peduncle, subthalamic nucleus, and ventral caudate, with an average YBOX score reduction of 45 to 60%. The reduction in symptoms tend to manifest weeks to months after the initial DBS stimulation is turned on, as opposed to with movement disorders where there tends to be a more rapid response. So now I'd like to introduce our guest speaker of the episode, Dr. Samir Sheth. He is currently on faculty at the Baylor College of Medicine. He's an associate professor. He is the Cullen Foundation Endowed Chair, a McNair Scholar, and the Vice Chair of Research. He's also a very active ASSFN member. And his research is supported by multiple NIH grants, and his research focuses in studying cognitive control, decision-making, and deep brain stimulation for psychiatric indications. So thank you, Dr. Sheth, for being here to chat with us today about DBS for OCD.
Well, thanks, Danica. This is a great pleasure. It's a great honor. I think it's going to be a lot of fun. Fantastic introduction to the topic. Would only have done it worse myself.
Thank you very much. So as some of you may know, there were recently published updates to the guidelines for DBS for OCD published by the CNS. So I wanted to briefly discuss those. The initial guidelines were published in 2014, and they stated that the use of bilateral deep brain stimulation is more effective in improving OCD symptoms than sham treatment. And this included a systematic review of 7 articles, with 3 of which had double-blind phase of active stimulation compared to sham treatment. So Since the publication of those guidelines, there have been several other studies that evaluated deep brain stimulation for OCD. And in 2020, the Guidelines Task Force conducted another systematic review of pertinent literature. And they included 10 additional studies, one of which was class 2 and 9 of which were class 3. These studies evaluated surgical targets, including the anterior limb of the internal capsule or the bed nucleus of stria terminalis. So as a result, the following recommendations were updated. The first recommendation states that clinicians should use bilateral subthalamic nucleus deep brain stimulation over best medical management for medically refractory OCD. So this recommendation had updated verbiage based on recent studies. The second recommendation was expanded to include the bed nucleus of the stria terminalis and now states that clinicians may use bilateral nucleus accumbens or bed nucleus of stria terminalis deep brain stimulation for treatment of medically refractory OCD. There still remains insufficient evidence to make a recommendation for the identification of the most effective target. And the prior statement of insufficient evidence to use unilateral DBS was removed since there was only one class 2 study and no new studies in the interim. Since these updates, the most commonly targeted regions are now the ventral capsule and ventral striatum, as well as the nucleus accumbens. Are these targets that you typically use, Dr. Sheth, in your treatment of patients with DBS for OCD?
Yes. And so, I think the interesting discussion point here, at least one of them, is, well, let me tell you two, and then we can broaden this discussion. So one, I think, is what is the difference between these targets? And the second thing is, what about the fact that we're only FDA approved to do the thing that doesn't have level 1 evidence? So, those are a couple topics we could chat about now, if that sounds good.
Yeah, absolutely.
Maybe we'll do that in the opposite order that I just stated them. But first of all, right, so the level 1 recommendations from that paper, and I'll say, I think it's just a great part of our field to be able to have guidelines committees that go through this and do the work so that the rest of us can just, follow the guidelines. So I think it's an awesome job that Michael Stout and the whole team did in publishing these. The funny thing is, they go by the evidence, they go by the published literature. And again, the single level 1 recommendation or guideline was bilateral STN, which is ventromedial STN, not the dorsolateral that we target for Parkinson's, of course, but bilateral STN, DBS, for OCD, and that's the only level 1 recommendation guideline. Now, as some of you listening to this may know, that sort of contradicts or sort of conflicts with the only form of regulatory FDA approval that we have in this country, which is for bilateral anterior limb of internal capsule, DBS. And so, that's been since 2009 is when the FDA, approved that humanitarian device exemption based approval. And so the highest level of evidence by guidelines is not something that we really have access to being able to do here in this country. Now, to unpack this a little bit, I think we can look from both sides. So, from the guideline standpoint, again, this is the way these are done is it's a very rigorous process. Everything is reviewed. There's certain criteria, and there has to be a minimum of this and that to be considered level 1, et cetera. So the study that really provided this level 1 evidence is the French study from Mallet and colleagues. I think it was around 2008 in New England Journal, where they did bilateral ventromedial STN DBS. It was a beautifully design study. There's patients are implanted. There's a crossover phase where each patient served as his or her own control, on then off or off then on in a double-blinded way. And if you look at response rates, they have a significant responder rate that is, that shows a significant difference between the on versus the off, again, in the individual patient serving as their own control. The asterisk there, though, that we talk about a lot, is that the criterion for response was set at a little bit lower bar than basically any other similar trial study series, et cetera, which is a 25% reduction in the the measure you mentioned, the Y-box scale, which is the standard measure. So 25% reduction was considered a response. Pretty much every other study trial uses a 35% criterion. So, it's a little bit of a higher bar. That's a bit of an asterisk with that study. In terms of the design, it was great. In terms of the responder rate, clearly significant difference between on versus off. But with that slightly different, and actually lower bar, one wonders, right? Whether according to the kind of currently accepted criteria, whether it would have shown the same results. Okay, and then from the other side, from the, let's call it anterior limb internal capsule side of things, there have been good studies, one of which actually is not yet published. The Brown group with Ben Greenberg led this. The study's finished and we're awaiting publication. But what is published is a study from some years ago from the group in Belgium, Bart Nutan's group, who, by the way, was the 1999 study that you first mentioned, the first description of DBS for OCD. So Dr. Nutan, they published this a few years ago. This is the bed nucleus stria terminalis trial. They used a different design, and I think that maybe kind of docked some points in terms of the guidelines committee to where it wasn't considered level 1 evidence. It's randomized and double-blinded, but their design was as follows. They had implant, and then they had an open label optimization phase that went on for many months, in some patients a year. And that was all open label to identify the optimal stimulation parameters, because, the thing with DBS for anything other than Parkinson's or tremor is, what are the optimal parameters? Who knows if they're the same ones that we use for movement disorders. Anyway, so they gave themselves, 8-12 months to optimize the parameters. And then in a double-blinded randomized fashion, they withdrew the stimulation, and they saw whether someone stayed better. Like if they got better and stayed better, that would be a sham response. But if they got better and then got worse with blinded discontinuation, that would be a true response. And sure enough, the patients who were getting true response, that were getting active stimulation, did better than those that were not. So it's a different design where they weren't just randomized right away after implantation. So I think from both sides, I think the class 1 evidence for ST and DBS is good, but there's a little bit of an asterisk in terms of that criterion. The evidence level from the anterior limb sort of camp is also pretty good. Maybe didn't quite meet the bar in terms of some of the specifics of the guidelines, but there are good data for that target as well. The study from Belgium that I mentioned, plus others that are ongoing. So, the bottom line is we do what we can do by approvals here. It's hard enough to get insurance approval even with the HDE. Insurance companies oftentimes will still fight you. So, it's hard to go so off label, in my opinion, and do the STN, which is pretty far off label, and have any chance of getting approval for it. Whereas the target that we do have approval for has a pretty good track record. So I'm actually pretty happy using it.
Right, which is ironic that the one target that we do have level 1 supportive evidence for is not one that is clinically used often.
Right. European groups definitely still use it. There's actually a nice trial that came out of Queen Square in London that did a head-to-head comparison of STN and ventral capsule or interlimb. And the quick, summary of that is that both groups, so they're implanted with 2 pairs of electrodes, STN and anterior limb, 6 patients. And again, they each served as their own control. They did one target versus the other target in a blinded randomized way. And the bottom line is, in terms of OCD symptoms, Y-box scale, both targets were very similar. The differences, though, were in terms of some of the other dimensions of comorbidities. So STN stimulation improved cognitive flexibility as measured by certain neuropsychological measures. Ventral capsule or anterior limb stimulation improved mood more. So there's a bit of a double dissociation in terms of cognitive versus mood features of the STN versus anterior limb targets, respectively. So this is very much an interesting area that should be explored further. There has not been another head-to-head study of those 2 targets since then. But you're right. I mean, the one that sort of has a more level of evidence we don't do, but the one we do is still pretty good.
Mm-hmm. And hopefully there will be ultimately level 1 evidence for those targets as well, but there are certain kind of barriers to that, being low recruitment or short length of follow-up, and as you mentioned, some insurance approval challenges for targets other than the ALIC. So
That's right.
hopefully
Right.
in our near future, we'll be able to see some more evidentiary support for
Yeah,
those.
exactly. I mean, this is an active area of research, and there's a number of groups, still actively involved, ours and many others. I promised to mention this target stuff. So should we talk about that for a second?
Yeah,
Um,
absolutely. How do
yeah,
you do it?
yeah. Well, so I think, I'll give my opinion, which is just that, the various names for these, targets that are all very close to each other, anterior limb of the internal capsule, ventral capsule, ventral striatum, nucleus accumbens, bed nucleus of stria terminalis, even, in my opinion, are kind of different names or guideposts of the same target, I would say. In my opinion, and a lot of people share this opinion, the target is a white matter target. It's not a little clump of neurons sitting in this tiny little septal nucleus called the BNST that like governs whether you have OCD or not. On the other hand, I think it really is the fibers that are passing through this mid to ventral portion of the anterior limb, which is conducting fibers from thalamus, basal ganglia, and brainstem to prefrontal regions, modulating the activity of those pathways, I think is really what we're doing. And I think the things that we can see, the nucleus accumbens, the BNST, these are, in my mind, guideposts. That's how I use them for planning, a way to kind of aim something to actually be able to see, because otherwise it's all just white. So that's how I consider them. And the nucleus accumbens is a bit anterior to the BNST. As you go posteriorly, the fibers are more compact. Another way of saying it, as you go more anteriorly, the fibers spread out, into the anterior limb through finally the corona radiata. So as you are posterior and close to the anterior commissure, the fibers are more compact, and I think that is a good bottleneck place that you can place the lead, whether it's just in front of the AC near the nucleus accumbens or just behind it near the BNST. I think somewhere in that area is the sweet spot. There's some great work. Suzanne Haber and her group had a paper a couple years ago. The title of it was something like 4 targets, are they different? Something like that. So, provocative, intentionally provocative title, which is just getting to this question of they're probably not different. They're probably just kind of different spots in the same region. Andy Horn and his colleagues have done some great DTI tractography work that, across many different groups, showing that perhaps there's this common fiber bundle that we're modulating when we see success with DBS for OCD. So a lot of good active work here. But again, I think the summary for me is that those 4 different things are not really different. It's just a different kind of names for really probably the same target that we're aiming for.
Right. Yeah, that absolutely makes sense. And finding a place where those targets kind of converge and we can target with one electrode, just maybe spanning across different contacts on that electrode may be helpful. Also, another thing that you kind of alluded to is that OCD is quite a heterogeneous disorder, and there's lots of different symptom presentations and severities. So tailoring the targeting to the patient's primary symptom presentation may be a way to best tailor the therapy to their disease. And there's oh, sorry, go on.
Yeah. I mean, I'll just pick up on that. I mean, I think, Danica, this is ultimately like one of the great goals I would say here is to be able to actually know enough to be able to target 2 individual symptom dimensions. So, DBS for OCD, okay, they all have OCD, right? But there's different flavors of OCD, there's different comorbidities. When will we understand the circuitry well enough to be able to say, okay, this patient has, a contamination OCD with a really severe mood component, but otherwise has a lot of insight, versus this other one, has harm avoidance OCD, with, real cognitive difficulties. So 2 different flavors of patients, are we really going to be targeting the same way? Should we be doing that? Or can we actually tease this apart a bit Again, this may involve, this likely will involve better just kind of circuit and white matter, and and kind of connectivity understanding. But to be able to do that in a patient-specific, individual-specific, symptom dimension-specific way is really, yeah, I'd say, a strong motivator of research.
Right, absolutely. And that's a perfect caveat into our discussion of a recently published article on which you're a co-author. So as part of an ongoing clinical trial for developing adaptive deep brain stimulation for OCD, Dr. Nicole Provenza, as well as you, Dr. Sheth, and several other co-authors published an article in Nature Medicine in 2021 that discussed the detection of neural signatures or neural biomarkers of these pathological behavior states in OCD that can be so varied. And that could be kind of the foundation for enabling adaptive DBS to improve efficacy for psychiatric disorders. There are several advantages of adaptive DBS because it can minimize undesirable stimulation-induced side effects, and stimulation will only be delivered when there are certain triggers or biomarkers present, which can ultimately save battery life and reduce the need for battery replacements. There's two important factors that this paper mentions to consider specifically with patients with OCD. And one is that there's typically a temporal mismatch between their symptom evolution and then the typical DBS stimulation adjustment schedule, as well as the lack of an objective biomarker of OCD symptom severity. We have the Y-box scale, but that's quite a subjective kind of patient-driven assessment of their symptom severity. So with that, you all studied 5 human patients with longstanding medically refractory OCD implanted with bilateral deep brain stimulation devices that were capable of recording local field potentials. And the targets that were included for these patients were the ventral striatum or the BNSD. And there were over 1,000 hours of recordings of LFP data from these patients, both in the clinic and at home. And it was while patients were doing unstructured activity and during exposure therapy. This included a wide range of symptom severity. And this led to identification of candidate neural biomarkers of OCD symptom intensity. In particular, the delta band showed a strong negative correlation with OCD symptom intensity, both in the right and the left BCBS. So this study was a really exciting step towards that personalized therapy and proof of concept for adaptive DBS for psychiatric disorders. Can you tell us a little bit more about this study and how it may help guide personalized treatment for OCD in the future?
Yeah, for sure. Yeah, thanks, Nika. I mean, so this was a heroic effort by a lot of people. I'll name a couple of representatives for this, this fantastic group. The PI of the study is Wayne Goodman, who's the chair of psychiatry here at Baylor. The guy who came up with the Y box. So back when he was at Yale, he's the Y in the Y box when he was at Yale. So, it's a privilege to work with him because he has so much experience, first at University of Florida and then Mount Sinai in New York and now here for a number of years. So it's fantastic working with him. It really takes, a huge team. Neurosurgery and psychiatry are critically important, but to do science like this, it takes, so much more. So it's a fantastic team. And Nicole did a great job. She's a postdoc in my lab now, so we're lucky enough to have her here for a bit of time. She did a great job putting together, all these data from these patients. These are challenging patients who are sick, and all 5 of the patients, met response criteria. So 100% response rate in that study. So that was super exciting. But even then, they're sick patients. The data are hard to get and they're hard to interpret. So I think Nicole and the whole group did a fantastic job of doing this yeoman's work. So, but you nailed it in the beginning. So the motivation really for this adaptive DBS for whatever, in this case OCD, are those 2 factors you mentioned are among the 2 key ones. So one is this temporal mismatch. You do an adjustment and it's not an immediate effect. I mean, it could take days, weeks, who knows how long to see a change or impact, in their OCD symptomatology. So how the heck do you relate what you're doing now to, how they're doing later, right? So, or when you're seeing them now, how do you know what you did before what impact that had, that causality, that temporal credit mismatch. I mean, it's a fantastic problem. And the other one is, the biomarker thing, right? So it's a subjective scale. The way you talk to these patients, is about how you're feeling, and it's very hard to measure it objectively. And so, what guideposts do you have to go by to make adjustments? And this is where there's so much artistry that comes into this. So those are both motivators. And by the way, those are exactly the things that are a lot easier in movement disorders. I mean, we have a lot of work to do in movement disorders. That is not a solved problem by any means, but the advantages it has there, that temporal mismatch is, almost non-existent. You turn on DBS, the tremor stops, you turn it off, it comes back. There's scales. I mean, there's, you can put an accelerometer on, you can get some really precise measurements of, a lot of these symptoms. And you don't have that with these psychiatric disorders, in particular OCD. So that was the goal of the study. So 5 patients, the first 2 were implanted with the Medtronic PC plus S, and then 3, 4, and 5 at the RC plus S. Most of the data came from the 3rd, 4th, and 5th, the RC plus S patients. Everything about that device is better in terms of research quality of data, et cetera. And so, like you said, I mean, 1,000 hours of recording in the clinic, but also at home. And that's, I think, what was really critical here. This was done, I mean, this is all pandemic Zoom era type of stuff. But patients would go on sprints where they would, for days at a time, do really dense recordings of high quality data on their device streamed to the tablet, in their house during just local, during just activities of daily living. It's not going to blow you away as a surprise, Anika, that, if I were to say that, OCD symptoms do not evolve over the course of months, which is perhaps the time interval of typical programming sessions. There may be a month or 2 months between them. And then whatever you're on at the last setting, at the last adjustment, is what you're on for the next month or 2 until you see the team again. But obviously the symptoms are changing during that time. And we were able to measure this, because we could densely measure, at a high temporal resolution, how their symptoms are doing using this symptom severity scale called the SUDS, OCD distress scale. So, dense measurements of that scale. It's still a kind of a subjective scale, but it's the best we got, tagged with LFP recordings from the electrodes. And that's what this device can do. It can not only stimulate, but also record, and you can stream the actual time domain data. So by getting, dozens, scores of measurements over the course of a few days, you could really see how, you could zoom in and have a much more granular appreciation of, between this measurement here and this measurement here, a month in between, there's a lot of variation between. And the LFP recorded, of course, at a very high temporal resolution, right, of hundreds of samples a second. And so you can then start to build a relationship between, when spectral power in a particular band, for example, changes, what does that have to do with changes in symptoms severity? And that's what Nicole and the group did, basically, was to kind of do that analysis in these 5, especially those 3 patients with the RC plus S. And as you say, found, some promising, kind of candidate signals of these low frequency spectral regions, delta power, for example, kind of a few hertz oscillations that really seem to vary with symptom severity. So plenty more work to be done to validate that, and then to perhaps use it prospectively in an adaptive fashion. But this was definitely the first step towards that goal.
Well, thank you so much, Dr. Sheth, for that wonderful summary of your landmark paper and your thoughts on the OCD guidelines. To wrap this podcast, we did some crowdsourcing and asked our audience to come up with a few questions for our guest today. And you, in your conversation earlier, have addressed plenty of those, which circled around appropriate patient selection for OCD, for DBS, pre-op imaging modalities, and the role of DTI and tractography, which targets are most suited, how can we make this a more patient-centered therapy. A couple of questions that I don't think we talked about in too much detail were it's a combined effort. As a neurosurgeon, we're the implanters, but our psychiatry colleagues take a big part of their responsibility on themselves in terms of evaluations, patient selection, and programming. In your experience, either inside the lab or outside of it, who do you think, in your opinion, should be taking the lead on adjusting stimulation settings and assessing response? And for a budding functional neurosurgeon who wants to incorporate this into their practice, what would be some pointers you would give them?
Yeah, thanks, Roshan. That's a great question. It cannot be overstated how important the involvement of psychiatry is here. We as neurosurgeons may occasionally do some DBS programming with movement disorders, in a pinch. I mean, I do very little. We have an awesome movement disorders group here. But this is a whole different ball of wax. These patients are sick in a way that we're used to sick, right? Like we take care of sick patients, but this is a different type of sick. I mean, this is not kind of ICU multi-system failure sick. This is just mentally, psychiatrically sick, very fragile, brittle, suicidal. I don't have any idea what most of these medications mean or even how to pronounce them. So how you take care of a patient in a holistic way who needs treatment, behaviorally, pharmacologically, and perhaps their DBS. This is why we need psychiatrists who really know how to do this. And the ones that really know how to do this make a tremendous difference. I think good targeting, good surgery, best practices in terms of how you choose a target, all that kind of stuff is kind of in our wheelhouse, and we owe it to our patients to be up to date with the latest and greatest in terms of how to do that. But that's at the most half the battle. The other half is managing the patient once the system's implanted. And this is what Dr. Goodman here does so well, and other there's a few other examples around the country of people who can do this well. So for someone who wants to get into this, because it is fantastically exciting, and I'm fully supportive of that. The barrier to entry really is being able to work with a psychiatrist who has that experience or who wants to gain that experience, even if they don't have it originally. And I think maybe they can work with some of the few who have it. There's workshops, and we're planning on putting on a conference actually this fall that is purely focused on training people, neurosurgery and psychiatry, who want to do this. I think that's what has to happen, so that the surgeon can have the confidence that they'll do the best job they can. The psychiatrist will then be able to really pick up the ball and keep running with it. I think that is going to be an important, that's probably one of the bigger limitations in our field right now. If a patient were to leave Houston and not be able to come back for programming here, there's only a few options of where they could go, and that's got to change for this to be able to be rolled out and be sustainable.
Fantastic. Well, thank you for taking the time to do this inaugural podcast with us. Danica and I are grateful to have you on as our guest. And
yes, thank you so much. Really are a pioneer in this field, so your insights are very valuable. And
pleasure, guys. Thanks so much.
And stay tuned for our next episode of the ASSFN podcast in April. We'll be discussing MRI-guided laser interstitial thermal therapy for medically refractory epilepsy with Dr. Jason Schwab. Thank you all for listening, and take care. See you for the next episode.
Thanks. Bye-bye.